To me, the important points for me first, legitimizing low T. I'm going to scream that from every roof, every physician, every colleague that I have to. And I have backup. You know that us, when we talk about this, it just doesn't come from personal experience. It just doesn't come from the thousands of patients I've treated. It comes from studies. As physicians, we need to be able to overcome our confirmation bias. I went to medical school in 1994. I was taught that testosterone causes prostate cancer. 2013, 2 studies came out that showed a possible link with heart disease. Now there's a black box warning on testosterone that it causes heart disease. So when patients come to us and they go see their primary care physician who's busy seeing 20, 30 patients a day who didn't keep up with the literature, he'll tell them, no, I don't agree with testosterone. I don't agree with testosterone. You're going to have those things. So the way I counterbalance this, we could go over all the literature, all the studies. We have a really good link on our website, and I'm going to tell you about it. It's the Mayo Clinic Proceedings. You can't get any more conservative and any more prestigious than the Mayo Clinic Proceedings. So they came up with they had an international expert meet back in 2017. It was 18 specialists, internal medicine, diabetologists, endocrinologists, urologists, that all met together, and they reviewed all the available data on literature on testosterone deficiency, and testosterone replacement. So they came up with 9 statements, and those 9 statements, all 18 scientists agreed with them anonymously. So I refer my patients a lot to that website because don't believe me. Look at what Mayo Clinic is saying. So the first thing they say, testosterone deficiency is a global health crisis. Testosterone deficiency is not just by a number. Testosterone deficiency and this testosterone replacement therapy is rational, effective, and safe. Those are not my words. Testosterone deficiency affects men of all ages. So when I started practicing, I said I would not treat patients less than 35. Within 5 years, I moved it to less than 30. Now I put it 25, and we get calls from patients who are 22, 20. They are suffering. It's hard for me to even treat them. So I partnered up with some urologists. My younger patients, I send them to the urologist just because we know it may not look good for a physician, especially me. I'm an internal medicine physician, but I consider myself an endocrinologist and urologist by default, because I study that, the literature is out there, so I can really discuss with endocrinologists and urologists toe to toe and go over studies with them and tell them why a lot of times they're wrong. This is outdated thinking. So this Mayo Clinic Proceedings, 9 statements, to me is a very powerful tool that patients can read. It's very easy reading, and you can even bring to your physician. Because a lot of our patients, that's what it is. They have a good relationship with their primary care physician. They come to me. I want to put them on a treatment that their primary care physician was not willing to do. And they're going to trust their primary care physician that they've had a very long relationship with. So my goal and what I'm trying to do, I don't want to bash those physicians. I'm also a conventional physician. I still do internal medicine. I still do primary care. So I'm also in that world. So my goal is to try to really help them educate the physician. It's not easy. Physicians tend to have big egos. If you go there, you're like, Doc, look at this. They close themselves. No, I don't want to hear it. It's bad for you. So my goal, and hopefully with the help of my book, with the help of what you're doing, what we're all doing, is to sensitize not only patients, but we really need to work on our colleagues to be like, listen to your patients. We get that a lot. Patients come to me, they go to their primary care physician, they do their annual lab, and they're like, I got A+ on everything. My doctor said my health, all my blood tests, maybe my cholesterol is a little elevated, but otherwise everything good. And I'm like, and how do you feel? I feel like crap. Really? Did you tell your primary care? It's like, yeah, but he told me maybe I'm working too much or I need a vacation. I'm like, all right, let's check your levels. A lot of those patients, we see low levels, and you correlate that with their clinical symptoms. So, and I'm going to say something. I don't put everybody who comes to me with a testosterone at 350 on testosterone. I have guys who come to me and they're like, hey, my friend is on this. Let me check. I'm like, how are you feeling? They're like, Doc, I'm great. Check level 350, 380. You don't need testosterone replacement. So we need level, and we need also symptoms. Once you put those two together, that's when, as physicians, we can do the evaluation and determine who needs it. But if we figure out that, yes, you do have symptoms and you have a suboptimal testosterone level, I'd much rather do a trial of testosterone than going down the route of diabetes medication, depression medication, or any of the tools that primary care physicians use, unfortunately.